Well, that was wonderful, Shripal. A fantastic overview of a very, very important seminal study that will absolutely make a big, big difference in how we evaluate patients with stable ischemic heart disease. So, a couple of things I think that was very important. Very, very early on in your slide set, you told us what ischemia, who it does not apply to, and I think this is really, really important because at the end of the day, there were a couple of things that I want everyone's input, but maybe we get you first to tell us. Number one, that the CTA ruled out left main disease, and these were really stable coronary disease patients with moderate to severe ischemia. But the baseline angina was really literally the average of about one episode per month. So in that way, anatomically they were high risk, I think, in some level, but symptomatically they were not really very high risk in that level. The second part that I think everyone has talked about is the intention to treat and how this is being translated and sort of broadcasted around the world, that PCI doesn't work again in stable ischemic heart disease, whereas I do believe that this was an invasive strategy versus a conservative strategy. I want you to talk about that, talk about the crossovers and how about 20% of the patients in the invasive arm did not receive revascularization, and the patients in the conservative arm that actually crossed over, and when we're going to see that as treated population. So which are the big questions for interventionalists. So sorry with that big question first, but I think that's what everybody wants you to talk about.
Yeah, absolutely. So Roxana, I think you hit upon the major aspects of it. One thing that I want to emphasize is ischemia is not a trial of stable angina. It's a trial of stable ischemic heart disease. And the way we designed it was to make sure that the primary intent was to see whether invasive strategy reduces cardiovascular events. I mean, it's as such, I mean, if you had included highly symptomatic patients, there would have been more crossovers and we really would not have answered this question. And that's one of the reasons. So this does not apply to patients who are highly symptomatic, they're dissatisfied with their therapy and they're continuing to have symptoms. Those are not the patients we enrolled, because this was not a stable angina trial. It was more stable ischemic heart disease. You're absolutely right that CCTA will play a critical role. And I think it all depends on your perspective, because what I see is if you have a symptomatic patient, you can either speak to him and say, look, you have two options, whether you want to pursue an invasive strategy where you potentially will feel better earlier and that the symptom relief is long lasting and potentially have a reduction in spontaneous MI, or do you want to try medication first for whatever short period of time, with the understanding that a proportion of these patients will need cath and revascularization down the line. And if they do opt for an invasive strategy, you don't need CCTA. You go for cath and you do optimal revasc as you deem fit. If you do choose a conservative strategy, I think there CCTA would play a role, and you have to make sure that patients don't have left main disease.
Yeah, that's a really good point. But Mitul, when do you choose, after seeing ischemia, when do you choose the invasive arm without any testing, or do you? What do you think about what what Shripal just said, Mitul?
Yeah, no, I mean, I think it's what he said is very important in the fact that this is a trial of ischemia. It's not a trial of angina. And so if a patient is reporting daily or weekly angina, you can, if they're resistant to undergoing an invasive angiogram, sure, a CTA is perfectly fine. But these are the patients that I think benefit more from revascularization. And to everyone's point here, I really wish that that more people understood what Dr. Bangalore just said, is that it's a trial of ischemia. And also, it's a trial of global revascularization versus a medical therapy arm. And I didn't see in any of the major headlines that were published after the trial was presented anything about surgical revascularization. And it was interesting how PCI at least in the lay press, was being slaughtered, but no one said anything about bypass surgery after the headlines hit.
And I think one of the things that we have to do as a community is not think about this as a slaughtering of our field, but rather another way for us to learn how to best treat our patients and use strategies that ischemia used in ways to evaluate and proceed. And what's the most important, I think, from ischemia, which I've learned, is that and I just practiced it just literally on a Thursday. I had a patient who came in, a 71-year-old woman with hypertension and hypothyroidism, and she's been having 10 years of symptoms of stable angina. And most recently, at another hospital, because of worsening symptoms, she got a stress test, and the stress test showed moderate to severe ischemia in a couple of territories. So previously we would jump and say, we need to like go to the cath lab. But the last episode of her chest pain was a month ago. So this is, to me, is an ischemia patient. And so I basically talked to her and I said, the only thing I can offer you is, if we bring you to the lab, is to, at the very least, help you with your symptoms, exercise capacity, and maybe reduce your angina medications, the meds, because she takes a lot of nitroglycerin. And I will not improve survival. And it may be some level of improving heart attacks down the line, but I can't promise and guarantee you that. And she chose to come to the cath lab, so she'll have an evaluation next week. So I think it's another way for us to kind of discuss this. Santiago, what do you think? How are you talking to your patients differently? Are you no longer going like this? I'm here to save your life.
I'm so happy we're having this conversation. I always felt very comfortable with the message of quality of life. And I think there is nothing wrong with that messaging to patients. In fact, I would argue that for many patients, quality of life is more important than longevity. And so I think we as a community need to understand that is an important variable, and that we are offering something meaningful to patients. And quite honestly, I don't quite understand this debate about the benefits of revascularization when someone is coming to us with symptoms of angina. When you think about other procedures, from orthopedic surgery to cataract surgery, the goal there is not to improve longevity, is to improve quality of life. And I think we have to be honest. I think that is not survival, but part of the problem is that these patients do not die. The reality is the patient with a stable, and Tim knows well, I mean, he set up the Optimist Clinic, and you look at the angiograms of these patients, they have multiple stents, previous CABG surgery, and you think these patients should have died 5 years ago, and they come every year to clinic, and they are just fine. Their only complaint is angina.
And I also think, Roxana, that I think we tend to divide quality of life into just angina. But quality of life is also the proportion of time, the risk that you're going to have to come back to the cath lab in 1 year, which we know is a crossover, and the risk of heart attack. And I agree with Santiago that they're not so scared of death. They're scared of another heart attack or a heart attack. And they don't want to come back to the hospital another year for another procedure if they continue to have symptoms or another unstable syndrome. So I think even though we have the data and we talked about shared decision making, I don't think we put ourselves in their position about what they really want. And we tend to still say, I only care about mortality, but maybe they don't.
Yeah, so we have to go to Naveen Kapoor, but I just want to hear 2 short comments, guys. I know these are not short comments. Ethan and Arnold, just quick short comments about your thoughts. Ethan, please unmute.
Hi. So I think one important distinction is spontaneous MI. So I'm in Portland, Oregon. I do see a lot of rural patients, and spontaneous MI in a rural patient is a much bigger deal than a spontaneous MI in a patient in a population center. So that's, I think, something to consider. But this is really helpful study, and I think shared decision-making is really the cornerstone of management going forward based on that.
Beautiful, Ethan. Very good point. And Shripal plans to continue following these patients. Arnold?
Yeah, thank you. I think that, a ischemia trial is going to be really, earth-shattering in terms of supporting PCI for quality of life issues, but also preventing spontaneous MIs. I mean, we see this in the FAME2 trial, of course. So, I mean, this is really a win for PCI, despite what it's been portrayed as in the press. And so we should present it as such. And I think patients will choose PCI over medical therapy anytime.